Greetings, colleagues and friends. Kambria Evans here, the Teaching and Learning EMDR consultant. And y'all, we are continuing our journey, our mission here at Zero Disturbance to rebrand trauma therapy. For those of y'all listening, I'm doing lots of air quotes here. And today on the podcast, we are going to be really diving into this question around when therapists say you're not ready for trauma therapy. Now, whether they're doing EMDR or brain spotting or talk therapy that's trauma-informed, I want to unpack this statement. If you are a client in therapy right now or you're thinking about going into therapy, if your therapist says this to you, I'm going to give you a list of things to ask them to understand that decision. And it should be a decision that y'all talk about. Your treatment plan should be collaborative. And so really the goal of this is to empower clients to get the most effective, efficient care that serves them so that they feel powerful in the process. And also to empower clinicians who identify as trauma-informed to make good choices. And when you make those choices, communicate them with your client to make sure that the relationship is respectful and we're not infantilizing our clients, right? They're adults. So I am very passionate about this topic because unfortunately, most of the people that I serve have been in lots of therapy. They've even been with other EMDR clinicians who have said things to them like, you're not ready to do EMDR. And my heart breaks, really. I mean, the anger I feel around this is protective because my heart breaks. Because what I want to say is there better be a damn good reason for you to say this. And you better be clear in your reason for you to choose to withhold or delay care for somebody who is suffering, right? Clients deserve that, right? And you as the clinician, I think sometimes we are told, oh, be careful about opening up trauma. Be careful about processing trauma. Whoa, it's scary. It's dangerous, right? And I think what we forget is that withholding or delaying care can be just, if not more, dangerous and unethical than starting care in most cases. And I'm going to hopefully have y'all convinced of this by the end of the episode today. So I want us to learn about this through analogies and metaphors because that's how we learn best. And I want us to think about if you were to walk into a doctor's office, a physician's office, let's say it's a surgeon, and let's say you were to go in and say, you know, I have this mass growing inside my stomach, and I want to have surgery to feel better, right? I'm not digesting things. My body feels off. My emotions feel terrible. All these symptoms. I'm depressed. I can't live my life. I can't be with my kids, right? The surgeon would never say, well, you're not ready for surgery, right? If the surgeon felt that was the case, the surgeon would then, ethically and responsibly, go on to describe why. And they would also say, here's what we need to do to get you ready for the surgery, right? There would be some empowerment and some action steps. There would be at minimum, some kind of a backup plan to help with symptom alleviation. There would be all of these things and more, right? Because any physician who left it at that would be taken to their board and likely put on some kind of discipline around their license. Therapists, I want you to think about yourselves in this situation. When someone comes to you and says, I'm suffering, I have all these trauma symptoms, right? I can't sleep. I have anxiety, panic attacks. I have disordered eating. I'm cutting, I'm depressed, whatever the symptoms are, you better have a really, really solid plan about how to get them to effective treatment, okay? Here's why, for the client, it hurts so badly to not get the care efficiently and quickly, right? Here's why it hurts so badly for the client to be told, you're not ready for trauma therapy. You're not ready for EMDR yet, right? Because as we've talked about in the previous episodes, trauma therapy isn't going back and focusing on the trauma, right? We're not doing that. The actual content of the actual trauma is not actually relevant in treatment. What's most relevant in treatment is what was learned or decided by your mind, emotions, and your body in terms of somatic symptoms, right? Did you decide from that assault, it's my fault? Did you decide when someone rejected you on the playground, I am bad, right? That is what you're carrying with you, okay? And then what adaptations were created in response to that? Well, I'm never going to get hurt again. So I'm not even going to make friends. I'm going to become avoidant in my attachment style. I'm not even going to risk rejection. I'm going to reject them before they reject me. That's an adaptation to something that was decided and learned at the age of 5. Okay. So that's what treatment focuses on, right? Really, we shouldn't even call it trauma therapy. We should call it, we should work with trauma therapists. We should work with learning-informed therapists, because this is how the mind learned, how the nervous system learned, how the body learns, right? The trauma is the trauma's done. What we're taking with us is what was decided or learned and the adaptations. Okay, so what's so painful for clients is to say you're not ready to feel better. You're not ready to do your trauma work. What we're actually saying to them is, I'm not available to take you on a rescue mission. I'm not available to go back in time with you and find all the parts of you that were betrayed, decided that you're alone, decided and learned that you can't count on and trust people, decided and or learned that you're not worthy, right? Now, some of these things you learned might have been true at that time, right? But these parts of us in these moments of time, they get stuck in that moment, right? They take that learning with us. And we're all walking around with all these parts of us with different moments of time of things we've learned and decided and all of the adaptations we created. So when I have a client come in and say, I have complex PTSD because of relational trauma with my parents, right? Let's say my parents were really neglectful. They were mean to me, said I was fat all the time, right? If I said to that client, well, you're not ready to do your trauma therapy, what I'm saying is I am not going to help us figure out how to go back in time and rescue these young, precious child parts of you that are stuck in this misery and still not soothed and still suffering. Why would you say that to someone? You better have a damn good reason, right? I hear this all the time too, when people are going into treatment centers. This is the system in the United States, for better or for worse. And this might be a separate episode, right? But when people go into treatment for alcohol, for disordered eating, really just for trauma, right? For things that they've learned or decided that are hard, and to help them with the adaptations around that. For people to not be getting access to EMDR therapy or brain spotting or any kind of brain-based modality therapy is completely clinically inappropriate, because you can start with anyone, anywhere, period. Unless someone walks into my office completely shit-faced with alcohol and on drugs, right? We can start every time. We can start, okay? So I always want to be a clinician who's available to go on a rescue mission with my client to go and reclaim and rescue younger parts of themselves, bring them into the present, help their body feel calm, and unlearn or relearn or learn for the first time what is actually true now, right? And any adaptations that were created that are causing maybe some relief, but also maybe some consequences or suffering, we're gonna bring them in too and love on them too. We're gonna love on all these parts, okay? The rescue mission needs to happen. Okay. So what do we need to have to do this? Like, let's really get into the nuances of what we mean when we say this, right? Well, I think we need to have 3 things. We need to have the right team. We need to have the right gear. And we need to have the right skill set. Okay. And I'm going to dissect each one of these so we understand what we mean about that. What's the right team? Okay. Well, a lot of people come in and work with me and they're like, I've been to talk therapy for 5 years, 10 years, 20 years. I'm not over this thing that happened that made me decide XYZ, that told me I'm not safe. I'm still triggered. I'm still upset. I still have this adaptation of, going out and chain smoking on my balcony. I don't want to do this anymore, but I don't know what else to do. I need to unlearn. I need to relearn. And the talk therapy only in my cognitive space is not enough. Okay, fantastic, right? Working with an EMDR consultant, working with a brain spotting therapist, working with someone who does art. These are all EMDR informed modalities, right? Brain-based modalities. This is where the protocol that we have comes in to give us something efficiently and quickly that talk therapy just can't do. And I'm not dissing talk therapists. This is just what research is telling us. And the research is the research, period. Okay. So we need to have the right team, right? And a lot of my clients come in, they have a talk therapist they see regularly, and I'm an adjunct EMDR therapist. That's okay too, right? Sometimes the team involves a psychiatrist if someone needs to have some medication for some short-term stabilization while they do the work to get through the hard processing and learning. The team might be a supportive partner, friend. It might be an AA group. It might be, a church community, but there has to be a team in place, right? And it can't just be the client, right? That's not a resourced person externally. Now, the client might have a lot of internal resources, so they don't have to have all those things necessarily, okay? What else do we need to have? We need to have gear, right? We need to have tools, right? About how to navigate this process. We need to have resources internally and externally, okay? Skills. This is, I think, the gold of this entire conversation around why someone is always ready to start trauma therapy, why someone is always ready to learn something for the first time, to relearn something or unlearn something, right? And when I say unlearn something, what I'm talking about is we learn a lot of things as kids that we can see as adults are total and complete bullshit, weren't even about us, and we're just about that person telling us the curriculum from their point of view, right? That's the unlearning. Like, oh yeah, that wasn't even true. Wasn't even about me. But I took it in as a kid because that's what kids do, right? Beautiful. So what are the skills? So I want to make this point really clear. So I'm going to give you 2 examples to drive it home, and then I'm going to talk about the skills needed to do the work. So y'all know I have twins. They're about to be 7. And they always want to learn everything. We promote learning in our house. We identify as lifelong learners, right? Mommy's always learning and making mistakes and relearning and unlearning, and it's all normal. It's all good. So if my daughter were to come to me and say, Mommy, I want to make a cake, right? I would never say to her, okay, great, let's go make the cake. And then get all the stuff out and have her come up to the counter on her little stool. And let's say she took an egg out and she went to go crack the egg in the bowl. But she'd never done that before, so she couldn't do it, right? Would I, as a loving, okay enough parent, ever say to her in response, well, it looks like you can't crack an egg, so we're not making a damn cake? That would devastate her. Devastate her. And this is like a fraction of the devastation. People who are suffering, who want therapy that's effective, this is how they feel when they're told, you're not ready, or you can't do this yet, right? Tell me why not. Well, you can't crack an egg. Well, teach me how to crack an egg. Teach me how to do that so I can put the cake together. Teach me the instructions and the steps. Give me the skill development. It's going to take me a long time to figure out how to crack an egg, right? At least without getting a lot of shells in the bowl, but then teach me how to get the shells out of the bowl. There's so many skills needed to make a cake. It's not just a protocol. There is skill development. And then what's really cool about the skill development is that it translates to other things, because now that she knows how to crack an egg, it generalizes. She can crack an egg to make a cake. She can crack an egg to make an omelet. Look at her cracking all the eggs, okay? You see where I'm going with this? It is our job as clinicians to give our clients skill development. This is what we do in education all the time. And I hope my next example really drives this point home too. When I was working at Stanford for 14 years at the medical school and the hospital, I was the director of education and quality improvement, okay? And one of the tasks that I had the honor of being a part of was we would have the first-year medical students come in, welcome them, and then we would give them a simulated patient interview. This is with a patient who was being played by an actor in like their first week of medical school. Right? So picture all these typically 22 to 25-year-old kids marching in, want to be doctors, paid all this money, did all this work to get here. This is really important to them. Their whole future depends on it, right? We put them in a room with an actor. They know it's an actor. And we say, this is your baseline assessment to medical interviewing. Okay. Why are we doing this? Because they need to learn how to do this. And one of the most effective ways we can help someone learn something new is when we look and show them in a loving way together, let's look and see what you don't know yet, right? We don't have medical students come out of that baseline medical interview with the actor and say, oh, well, you know what? You don't really know what medical questions to ask, or you don't really know how to get a patient history, or you don't really have your bedside manner sucks. Guess you can't be a doctor. Sorry, take your $250,000 back and go do something else with your life. Could you imagine? I mean, it's ridiculous in these examples, but I want to drive this home. We help these people learn how to care for other people, because that's part of our job. And part of our job as clinicians, and if you're a client and your therapist is not doing this for you, this is a huge red flag, right? Every relationship has red flags. I want you to look for red flags in your relationship with your therapist. Your therapist should be helping you with skill development. Okay. So, what are the skills that we need to either have or develop in order to do the work? I'm so happy that you asked, because I've thought a lot about this, right? And I'm going to share with you a framework that I use to let myself and my client, and I share this with my clients openly. Here's the framework, here's the checklist we're going to use so that both of us feel comfortable to know that you are locked and loaded and ready to go with EMDR phase 4, ready to process this traumatic event, ready to undo that learning, relearn, ready to change the way your body feels, ready to desensitize your triggers. I'm stoked. Let's do this. Okay. So I'm going to share the framework with you, and I want you to think it through with me. Okay. So I believe in order to do EMDR, or really most brain-based modality trauma therapy, we need 6 skills. Okay. So the first skill, we have to learn how to notice our body, okay? It's a relationship with our body. Even if it's just noticing, I don't feel anything in my body, I'm totally numb, we're noticing it, right? We have to be able to notice our emotions. Number 2, how do I feel when I talk about this? I feel passionate. I feel impatient. I feel frustrated. I feel pissed off. Right? That people aren't getting the care they deserve when they deserve it. We have to, number 3, we have to notice our thoughts. And specifically with EMDR, we notice a lot around our negative beliefs and positive beliefs, right? Because when we have a target we're focusing on, we typically identify the negative belief we're starting from and the positive belief we want to end on. Typically, it's something like, I am not safe to I am safe now. Or something like, I am not worthy to I am worthy. Right? If it's stuff under 5 years old, oftentimes it's around I am bad, I am good, or good enough. right? I am powerless to I have choices, okay? So we have to notice these things because this informs the narrative we are carrying around with us, right? These parts of us that have gotten this curriculum from other people or other experiences. Beautiful. Okay, y'all still with me? Number 4, we need to notice where our mind goes. So what does that mean? We have to notice, oh, I was thinking about being in my car, and then I was thinking about being on the bus going to school, and then I was thinking about being in the sandbox. Like, we have to notice where our mind goes. And oftentimes when we do these brain-based modalities like brain spotting and EMDR in art, we do what I call time travel, right? We time travel through all the curriculum and all these experiences to kind of like do an inventory of like, what did I learn about this? And how did I put that information together in my thoughts, in my heart, in my body, that is informing all of my relationships with myself and other people. Okay. Number 5, we need to stay in the room with the therapist, meaning for my clients to be able to do EMDR, they need to have dual awareness. What does that mean? It means that there is a sense of I'm here in the room with you in the present time, and I'm also time traveling. I'm also in the 2nd grade right now and looking at that. And I'm also back in the sandbox. I'm also back in my first marriage, right? I'm with you in the office and I'm here. And I have dual awareness of both, right? Beautiful. Number 6. And this is one that I think is really important and oftentimes needs skill development. We need to be able to, as the client, report to the therapist if these things are happening or not happening, right? Oftentimes we hear this in phase 4 of EMDR when processing a trauma target. My clients will say to me, I'm not moving anywhere. Like I'm kind of stuck in the sandbox. Like I'm not going anywhere, right? Such beautiful noticing, okay? Or I might say something like, what is the emotion that goes with those words? I'm not able to tell you the emotion. I can't, right? So it's the client's ability to tell the therapist if numbers 1 through 5 are happening or not happening. Nothing's wrong if they're not happening. It's just that ability to say, here's what's happening or not happening, and figuring that out from there. Okay. So if a client can do these six things good enough, right, then they have, figured these things out, like they've learned these things, then we're good to go. Okay. But if a client needs some help in one of these areas, we build these skills intentionally through drills. Okay. What is a drill? Have y'all ever played any sport? Have y'all ever done any theater, right? You have play practice. You go over your lines, right? When you play a sport, I used to play field hockey. We would run up and down the field and like go through cones and dribble and practice hitting into the net. We're doing drills to build muscle memory and skills to be able to do these things quickly in real time because they're so automatic. Those neural networks are so strong. I can access them because I've done drills to build and strengthen them up just like a muscle, just like lifting weights. Okay? So, an effective drill and practice training takes on the following measures, okay? Thinking about organize and structure the lessons or activities so as to like put emphasis on reinforcement of previously learned concepts, right? So we think about skill building. Like let's say my daughter can crack the egg, but then there's shells in the bowl. So we got to figure out, okay, how do we, so you oftentimes will kind of stack on these skills. We always want to provide immediate feedback, right? Or answers to solve problems as we get stuck, right? If my daughter cracks the egg and it goes all over her hand, I'll say, let's be curious. Like what happened here and how can we try again? Let's do an experiment to try it again in a different way, right? Maybe not so tight in your hand this time, okay? The first year of medical school at Stanford, there's got to be tons, weekly practice skill development, drills around medical interviewing before we even let medical students talk to real patients in the hospital in their clerkships in year 3, right? I mean, same with therapists. We do lots of practicing talking to clients before we are allowed to go and actually talk to real clients in real life. Okay? This is just part of how education and part of how learning works. We want to have some kind of management system to track the learner's progress. I'll give you guys a image of, or like a chart of how I do it. And we need to allow learners to master learning materials at their own pace. Okay? I would invite every clinician who says they are trauma-informed to, first of all, think of yourself as learning-informed, because really you're a learning specialist. And secondly, I want you to say to your clients, of course we can start doing this work. Of course we can start figuring this out and helping you feel better. Let's figure out what we're working with. Let's figure out what skills we want to develop. And let's figure out how we're going to do that, how we're going to learn those things. Let's figure out what drills we're going to do, right? Noticing your emotions and your body and that observer part of you that can hold dual awareness. Like, let's figure out how to do those things, right? Let's start now. Is a much more appropriate and ethical response than you're not ready, right? You're not ready because something's wrong with you, when really I, as the learning specialist or the trauma therapist, don't understand these concepts or how to help you learn them. Like, let's just own our ability to do better here, okay? All right. So what system do I use to assess readiness? Okay, well, we already have the 6 skills. How do I know if we're good to go? I hope y'all have seen a stoplight, right? Red light, yellow light, green light. It's that easy. The minute my client walks in the door or meets me virtually for working together, I ask myself, okay, can they notice their body? Can they notice their emotions? Can they notice their thoughts? Can they notice where their mind goes? Can they maintain dual awareness? Can they report if that's happening or not? And then I just write down green light, yellow light, red light. If I have a red light, like, wow, this person really is just like not able to notice where their mind goes or not able to notice their body at all, right? Then my job as the therapist, this is not the client's fault. I'm probably bumping up against a really protective, important adaptation. I'm not going to judge it. I'm not going to shame it. It's there for a reason. Or they haven't learned this yet. Also not their fault, right? It's my responsibility as the clinician to then say, I would love you and I to do some practice in preparation for doing phase 4 of EMDR around your skill set around noticing your body. And I'll say it like this. I'll say, you know what? You deserve to be able to notice your body, or you deserve to be able to notice your emotions. Do you think you deserve that? Because if you do, like, I have a plan for us to give that and develop that for you. They always say yes. Okay. So then we do drills, right? How do we do drills? If we're just talking, right? We're just talking in therapy. I might say if we have a red light around noticing emotion, I will consistently ask them, and what's the emotion that goes with those words? And as you say that to me, what's the emotion that goes with those words? And as you notice that pit in your stomach, what's the emotion that goes with that? I'm connecting with them, their body, their thoughts, and their emotions. This is Karate Kid, right? This is Daniel painting the fence and washing the cars. This is all drill practice in preparation for EMDR phase 4 and phase 2, really. Resourcing. Okay. That's all it is. And it's my job to do it. Period. Okay. So if someone is mostly greens and yellows, we're cool. Reds, we just bump them up to yellow. They don't have to be at a green. Who cares? Let's just go good enough. Let's go good enough. Okay. So what are some examples of drill practice plans? Okay. How do we notice our body? Well, we could do a body scan. What does that mean? I'm going to scan my entire body, starting at the top of my head, going down as long as it takes to notice any body sensations, whether they feel positive, neutral, or negative. Just going to notice my body, right? That's drill practice. Okay. So I'm hoping this is making sense. I'm hoping this is feeling helpful. Okay. And when we bump up against adaptations, I want to and I'll talk about this in another episode too, but we bump up against adaptations. Like, what does that mean? Is there a part of you that has learned not to notice your body, right? An adaptation. A part of you that's learned not to notice your emotions because that's overwhelming or that's scary, okay? What I'll say to my clients is, if a part of you has learned to not notice your body, and that comes into our time together, I ask permission. Can we notice that together? They always say yes. And then I say, okay, if yes, can we be curious together about how we want to respond to that old learning while we're in the new learning process, right? And they always say yes, because we're just being curious. We're figuring out how to hold old learning, right? Adaptations, like don't feel that, don't feel your body, right? All of that is data and all of it is good. All of it is good in terms of your clinical reasoning to help your clients, period. Okay. And we're going to talk, as we talk about rebranding trauma therapy, we're going to talk a lot in this series about adaptations. We're going to talk a lot about how to embrace people's adaptations because they help them survive some really hard shit. Like those adaptations, those people weren't born with those, right? You were not born with a desire to get drunk every night, right? It's an adaptation that was created for a good reason. And we're going to talk a lot about shame and adaptations too, because that's another, I think, really unethical thing that's happening in mental health care right now. So I hope that you will be curious about that with me as well. So take homes today. If you're a clinician, I hope this has sparked some curiosity in the way you talk to your patients. And if you are someone in therapy, I hope this empowers you to feel like you understand what you deserve as a co-collaborator, as an empowered member of your treatment plan and your care process, okay? And if you're someone who's really feeling curious about this with me and you want to keep learning with me, I would invite you to sign up for the mailing list. There's a link below. We send out lots of information about everything mental health, everything self-care and well-being, and I hope that you'll continue to be curious with us in those conversations. So it was so good to be with all of you. I look forward to being together again real soon. And then in the meantime, please take good care of yourself.